Local anesthetic cartridge vials. Local anesthetic cartridge contain the following ingredients. Number 1, local anesthetic drug. 2, vasoconstrictor drug. 3, preservative for the vasoconstrictor. 4, ringers solution. 5, distilled water. 6, general preservative. Local anesthetic drugs are agents. Local anesthetics are drugs which upon topical application or local injection cause reversible loss of sensory perception, especially of pain in a restricted area of the body. It provides pain control during dental therapy. It interrupts propagation of impulse, preventing it from reaching the brain. These drugs are listed by their concentration, their percent concentration. The number of milligrams of an agent contained in the cartridge can be calculated by the number of ml in the cartridge. Thus, a cartridge containing 2 ml of 2% local anesthetic solution contain 40 mg of local anesthetic agents, as 2% equal to 20 mg per ml by 2. The number of ml in the cartridge is equal to 40 mg of local anesthetic agents. Okay? Properties of an ideal local anesthetic agents. Despite the constant development of new drugs, the ideal local anesthetic agents has yet to be introduced into clinical practice. However, it is useful to consider the requirement of the ideal agent when assessing it. It should have the following properties. A, potency and reliability. The first requirement of such substance is that when administered correctly and in adequate dosage, it constantly produces effective local anesthesia. Earlier agents, example cocaine, were obtained from the natural source, and there was considerable variation in their purity, potency, and reliability. These problems have been overcome by present-day methods of production and packaging. Thus, experiences has shown that approximately 98% of the injections use 2% lignocaine with 1 to 80,000 adrenaline solution are followed by effective anesthesia. B. Reversibility of action. The action of any drug used to obtain local anesthesia must be completely reversible within a predictable time. C. Safety. All local anesthetic agents must have a wide margin of safety from the poisonous side effects, which are collectively known as toxicity. D. Lack of irritation. No injury to or irritation of the nerves of the tissues should result from the injection of a local anesthetic agent. For this reason, local anesthetic solutions should be isotonic and have a pH compatible with that of the tissues. A. Rapidity of onset. Ideally, the injection of such an agent should be followed immediately by the onset of local anesthesia. Experiments have shown that the mean onset time following infiltration anesthesia using 2% lignocaine with 1 to 80,000 adrenaline solution is about 1 minute and 20 seconds. And duration of effect. In theory, recovery of cessation should coincide with the completion of treatment. In practice, the duration of anesthesia is usually longer than is required for dental procedures. G. Sterility. Since local anesthetic agents are introduced into the tissues, it must be possible to sterilize them without affecting either their structure or properties. H. Adequate shelf life. Unless the local anesthetic agent is stable in solution and compatible with other constituents, the shelf life of the preparation will be reduced. I. Penetration of mucous membrane. Ideally, the drug should have the property of penetrating mucous membrane. Okay? G. It should be relatively free from producing allergic reactions. K. It should be stable in a solution and readily undergo by transformation in the body. Then we come to classification of local anesthesia. The local anesthetic agents could be classified in various ways. Number 1, on the basis of occurrence in nature. A. Naturally occurring. Example, cocaine. B. Synthetic compounds. Example, procaine, lignocaine, eucracaine. 2. On the basis of duration of action, A. Short-acting as articaine, lidocaine, and prolicaine. B. Long-acting as ubivacaine and bupicaine. 3. On the basis of chemical structure, A. Ester, B. amide. Is structure of local anesthesia, the ester and the amide. All the local anesthetic both lipophilic and hydrophilic characteristics, generally at opposite ends of the molecule. The ester type includes the following: number 1, brocaine, 2, chlorobrocaine, 3, roboxicaine, 4, butycaine, 5, cocaine, and 6, mesocaine. The amide types include the following: lidocaine, 2, prolicaine, 3, articaine, and 4, ubivacaine, 5, lidocaine, and 6, etidocaine. Now come to the pharmacokinetics of local anesthesia. Distribution. Once absorbed into the blood local anesthetics are distributed throughout the body to all tissues. The blood level of local anesthetic is influenced by the following factors: A. Rate at which the drug is absorbed into the cardiovascular system. B. Rate of distribution of drug from the vascular compartment to the tissue. More rapid in healthy patients than in those who are medically compromised as congestive heart failure patients. C. Elimination of the drug throughout the metabolic or excretory pathways. Then we come to the metabolism. A. Ester local anesthesia. Ester local anesthetics are hydrolyzed in the plasma by the enzyme pseudokinase. Brocaine undergoes hydrolysis to paraminobenzoic acid, which is excreted unchanged in the urine. Allergic reactions that occur in response to ester drugs are usually not related to the parent compound as brocaine, but rather to para-aminobenzoic acid, which is the major metabolic product of ester local anesthetics. People having a typical form of pseudokinase gain inability to hydrolyze ester local anesthetics and other chemically related drugs, thus reducing high blood levels of the local anesthetic and an increased potential for toxicity. B. Amide local anesthetics. The metabolism of the amide type is more complex and somewhat slower than that of ester type. It appears that breakdown does not occur in the bloodstream and that hydrolysis takes place mainly in the presence of catalysts in the liver. The products are then oxidized further and some conjugation with the glucouric acid takes place finally. Conjugate and unconjugated products are excreted in the urine. Excretion. The kidney are the primary organ for both the local anesthetics and its metabolites. A percent of a given dose of local anesthetics drug will be excreted unchanged in the urine and thus varies according to the drug. Esters appear in only very small concentration as in the parent compound in the urine. This is because they are hydrolyzed almost completely in the plasma. Amides are usually present in the urine. This is because they are hydrolyzed almost completely in a greater percent than esters. Because of their more complex process of biotransformation, patients with a significant renal impairment may be unable to eliminate the local anesthetic compound and its metabolites from the blood, resulting in slightly elevated blood levels and an increased potential for toxicity. This may occur with either the esters or the amide drugs. Esters appear in very small concentration in the urine as a parent compound. This is because they hydrolyze almost completely in the plasma. Brocaine appears in the urine as a paraminobenzoic acid 90% and 2% unchanged. 10% of the cocaine is found in the urine unchanged. Amide usually are present in the urine as a parent compound in a greater percent than ester because of their more complex process of biotransformation. Studies found less than 30% lidocaine, 1% bupicaine, and 1% of etidocaine are found unchanged in the urine. Common local anesthetic agents: lidocaine, lidocaine, or xylocaine. Lidocaine, it is the most commonly used local anesthetic agent in dentistry. It is the first non-ester type local anesthetic agent to be used in dentistry. It is stable as it can be stored for a long time at a room temperature, with time boiling and autoclaving. It is compatible with all types of vasoconstrictors. Pharmacology and biotransformation. Diffusion is rapidly diffused through interstitial tissue into lipid-rich nerve, giving a rapid onset of anesthesia. Biotransformation. Lidocaine undergoes biotransformation in the liver. A. Metabolism. Lidocaine metabolized in the liver by macrosomal fixed function oxidase. B. Excretion. Lidocaine and its breakdown products are excreted to some extent in the urine by kidney. C. Potency, 2 times more potent than brocaine. Today, it is taken as standard for comparison of various other local anesthetic agents. D. Toxicity, 2 times as toxic as brocaine. E. Time of onset of action, rapid, 2 to 3 minutes. F. Effective dental concentration is 2%. G. Anesthetic half-life 1.6 hours. Maximum recommended dose for lidocaine with or without a vasoconstrictor is 4.4 mg per kilogram body weight. Availability in dentistry: dental cartridge of 2% lidocaine with epinephrine, 1 to 80,000. Other popular local anesthetic agents are lignocaine, bupivacaine, and brolocaine. This is a table showing the comparison of various other local anesthetic agents. Selection of local anesthetic agent. There are several anesthetic agents available for use in dentistry. Each agent has got on its own indications. The agents are selected on the basis of the need of each patient. The following factors are to be considered for a selection of a particular agent. Number 1, duration of action. 2, need for control of postoperative pain. 3, physical and mental state of the patient. 4, concomitant medications. Duration of action. It is an important aspect. An approximate duration for completion of surgical procedure for which anesthesia is required should be taken into account. The working time should be adequate. On the basis of duration of action of local anesthetic agent, local anesthetic agent could be grouped as: number 1, ultra short acting agents where the duration of action is less than 30 minutes, as number 1, brocaine without vasoconstrictor. B. 2% lidocaine without vasoconstrictor. C. 4% brolocaine without vasoconstrictor. Two short-acting agents where the duration of action is 45 to 75 minutes. A. 2% lidocaine with vasoconstrictor. B. 2% bupivacaine with vasoconstrictor. 3 medium-acting agents where the duration of action is 90 to 150 minutes, as 4% brolocaine with vasoconstrictor. 4 long-acting agents where the duration of action is 180 minutes or longer, as 0.5% bupivacaine. Need for control of pain. Most of the oral surgical procedures result in varying amount of postoperative pain. Local anesthetic agent serves as additional medication that sometimes eliminate the need for postoperative analgesia. The local anesthetic agent that have shown to produce longer duration of analgesia even after the other sensation have returned are bupivacaine and ethanocaine. Physical, medical, and mental states of the patients. Any coexisting medical conditions such as hypertension, diabetes should be considered. A patient with history of allergy to a specific local anesthetic agents or any other components used along with the local anesthetic agents should be considered. The mental states of the patient have to be evaluated, as small children and mentally retarded patients may traumatize their lip, tongue, or cheeks due to the effect of local anesthesia. Hence, for these reasons, their use of long-acting local anesthetic agents is contraindicated in such patients. Concomitant indication: the use of vasoconstrictor is contraindicated in patients who are taking monoamine oxidase inhibitors and tricyclic antidepressants. Thank you for your listening.